I'm Biswanath Tripathy from Fakirmon Medical College and Hospital, Baleswar. And today we are going to learn a very important concept of radial pulse. It is important for your physiology practicals as well as your theory exams. And also in your clinical years, you will face challenges relating to this topic. So you must have a firm basic so as to understand this topic a bit more leveled up you read Harrison's or any other clinical based textbook. Okay. So radial pulse, you have to understand what is radial pulse. So basically, the rhythmic and the expansion, you can say, uh, when the pressure waves are transmitted along the arteries produced in each systole. Okay, this is called as radial pulse. Okay, you know the location of radial artery from your anatomy knowledge. Okay, and just remember, let's give the heading radial pulse. So many of you are requesting many one-shot videos for excretory system and embryology and others. Okay, so don't worry. It will take time, but I will surely try to cover up all the topics. Just I'm taking the short topics first because due to that busy schedule and all, I can just go on teaching all of them. Okay, so just understand that it will take time, but in due course of time, we'll get it. And if you're facing problems, just you can connect me on Instagram and ask your doubts if you are reading that part of topic or you are solving questions of any specific topic, you can just ask me out. Okay. So radial pulse. Radial pulse is the rhythmic expansion of the radial artery. Okay. When the pressure waves are transmitted. We know the systole, diastole, and other basic things. I'm not going into that depth. Okay, I'm discussing here the practical aspects which you have to understand. Okay, so radial artery is palpated by three fingers. Basically, if you google the images of radial pulse and how to feel the radial pulse, they will show you like they are putting two fingers only. Okay, that is incorrect. Okay, the three fingers are used for palpation. So radial pulse is only palpated by three fingers. Just understand this. And these three fingers have specific importance. One is called the proximal finger, one is the middle finger, and one is the distal finger. Okay, you'll read in future videos what are they mean and how to uh, apply pressure on each finger so as to get a perfect pulse. Okay, so this finger, which is you can say nearer, in layman terms I'm telling, if it is nearer to your little finger, this one is the proximal finger, and this is the middle finger, and this is the distal one. Okay, so these three fingers are used for palpation of radial pulse. So what we'll do, just you can see that if this is my hand and radial artery will be on the lateral side, of course you know lara. Okay, lateral radial, understood? So here you'll feel an artery. Then you'll put your three fingers and occlude the artery. On occlusion, you'll feel some of the pulses. You'll use an analog watch. You'll wear an analog watch here and measure 60 seconds. If you don't have time, basically what clinicians do is that they see 6 seconds. Okay, 6 seconds and multiply it by 10, which will roughly give you the radial pulse for 60 seconds. Okay, so basically you have to check, and you have to check bilaterally in a patient to check if there is any radio-radial delay. Radio-radial delay means one hand radial pulse will not match with other hand's radial pulse. There will be a delay or fastness. Okay, so basically you have to check the radio-radial delay. You have to check the pulse bilaterally, right? These are the basic things you have to pay attention in your practicals. Okay, and this hand is basically not placed like that. It's not flat like that. We basically say that we should have a semi pronated forearm and a semi flexed wrist joint for measurement. Okay, we should have a semi pronated forearm and a semi flexed wrist joint in order to measure the radial pulse. Okay, okay, so basically now we are into the radial pulse topic proper, and we'll see what are the points you have to note in order to see a perfect radial pulse, what are the things you have to note here? Okay, how to note, what to do will face in clinical years, but we are discussing only the basics which you have to know in as per the first year point of view. Okay, so what are the points to note? Basically, just note down. First, you'll see the rate. Okay, the radial pulse base, the rate you have to know 60 to 100 beats per minute. Okay, 60 to 100. And average, you will calculate 72. Okay, 72 BPM, beats per minute is the unit. Okay, so you have to check the rate. You have to check the rhythm. Okay, if it is a regular rhythm pulse or a irregular rhythm pulse, you have to check the force. Weakly felt pulses are there, strongly felt pulses are there, many things are there. Volume, tension, you have to note this all. Volume, okay, attention. Of course, you can't know all the things basically, but in clinical years, you'll learn how to check each of the thing. A rough estimation is important from this point of view. We'll discuss some pathological pulses also. I'll tell you many things which will give you an extra edge if you read other clinical textbooks like Harrison's and all. Okay, and you'll see the condition of arterial wall, condition of arterial wall. Of course, you know that in older people we have atherosclerosis developing. Okay, so the pulses, the hands, you'll see the they're veiny. Okay, the arteries and veins, they are basically uh, more palpable as in compared to a younger person. Okay, then we'll see an apex pulse deficit. Apex pulse deficit, right? Apex pulse, apex beat, you must have been knowing. Okay, and as I told, we'll check delays also. Radial delay, radio femoral delay. Okay, so there are two types of delays. We have radio radial delay. Okay, radio radial, that is checking the bilaterality of bilateral equality basically between the two radial arteries, right? And we have the radio femoral delay also. Radio femoral delay, radio radial delay and radio femoral delay are to be checked. Femoral pulse is to be felt in normal. Okay, basically you are if you are in first year and you are doing the practicals and the examiner asks you to give a radial pulse. Okay, just a minute. Okay, sorry for interruption. Yeah. So delays, I was talking about radio radial delay and radio femoral delay. So basically you have to check the pulse on femoral artery as well and compare it with the radial artery. Okay. There must not be any delay. So in the first year, you have to write all things normal. Okay. Abnormal things are coming in later years. So as to understand the abnormal things, you have to know the normal things first, right? There must be no delay between left and right hand pulses, and then there must be not any delay between the radial pulse as well as the femoral pulse, right? And the last thing, you have to check all the peripheral pulses, all the peripheral pulses, right? Uh, so basically, these are the things which you have to understand. Okay, peripheral pulse, like femoral pulse, carotid pulse, the pulse of dorsalis pedis artery, and many other things are there, right? So if I talk about rate, let's move on to each of the parameters in detail. Let's talk about rate first. Rate is basically the normal is 60 to 100 beats per minute. Right, 60 to 100 beats per minute. And if I talk, if there is a less than 60, we call it bradycardia, right? Less than 60 is bradycardia. More than 100 is tachycardia. You're knowing these things, right? Bradycardia and tachycardia. So bradycardia, it may be physiological as well as it may be pathological. Likewise, tachycardia can be physiological as well as pathological. So questions arise that which conditions are there in which you get a physiological bradycardia and a pathological bradycardia, and so on with the tachycardia, right? So bradycardia may be physiological or it may be pathological. Tachycardia can be physiological or may be pathological. So what are the conditions? So physiological, just think, how when will your heart rate be slow when you sleep, right? So physiological, just remember sleep. Okay, and athletes too. Due to increased vagal tone in athletes, there is an increased parasympathetic tone, okay, vagal tone. So in athletes, due to increased vagal tone, you get a physiological bradycardia, right? And pathological in which conditions? Let's say we have heart block, okay, heart block. Of course, the beating will be slower, right? Or you get an myxedema, right? Myxedema is one of the conditions. These are tachycardia. So physiological tachycardia and pathological tachycardia. What are the conditions? So in physiological tachycardia, just think what are the conditions which the heart rate increases. Of course, when you get more excited, when you exercise, okay. In your newborns, okay. Many conditions are there. So you can just write three one. I told exercise, emotions, or in neonates, right? What are the conditions in this is pathological tachycardia? You can just think of these conditions, right? You have to just apply common sense. I'm running out of colors. Okay, physiological fever. Okay, then many diseases are there, right? Your Paget's disease. Okay, your PNH or paroxysmal nocturnal hemoglobinuria and thyrotoxicosis. Okay, you can write many things. So atrial flutter fibrillation. These are atrial flutter. I'm writing fever. Okay, then other conditions you can write many of them. Okay, I'm not Paget's disease. You just write these all conditions, right? So these are the conditions in which there is pathological tachycardia. Okay, and some drugs will be causing bradycardia and some drugs will be causing tachycardia. Okay, many drugs are there. Just remember the drugs which are causing the bradycardia. Okay, you may get these drugs if you read Ganon, and sometimes you may get confused. So basically, two drugs just to remember: beta blockers. In second year, you will learn more drugs: beta blockers and you write digitalis. Okay, so beta blocker basically like propranolol, cartiolol, labetalol, many things are there, right? And digitalis is obtained from plant product. Okay, so just no need to go into detail. Just digitalis and propranolol, these are basically will cause bradycardia. These both drugs will cause bradycardia, right? Let's move on. After rate, we'll go to rhythm. Rhythm. So what to know about rhythm? Either it is regularly rhythm, okay, or irregular rhythm, right? Occurring in regular intervals or irregular. So in first year you'll get regular rhythms. Okay, if you get an irregular rhythm also, you'll of course you can differentiate between irregular and irregular in this point of time. But if you get in your practicals, just say it is regular rhythm. Okay, don't get into controversies. And irregular. Then we have two other differentiations also, like regularly irregular or irregularly irregular, right? You can get regularly irregular or you can get irregularly irregular. Okay, these are just you write for completion's sake. Okay, then third thing, we know force of contraction of this radial artery. Okay, so the proximal finger basically, I'm just giving an overview. The proximal finger will if you obliterate the radial artery with the middle finger, just basically the obliterating finger is the middle finger. So the pressure, the force or pressure is felt by the proximal finger. Okay, so proximal finger is used to feel the force. Okay, so basically you are obliterating, this is the obliterating finger. Okay, and this proximal finger basically you are feeling the force in. Okay, understood? This much you have to know. Just don't deviate yourself or go into more details. Okay. Fourth thing is the volume, right? After pressure, sorry, force, we get volume. So what about volume? Volume is basically the amplitude, okay? The degree of expansion of the artery under the middle finger. How much the artery is getting expanding, how much the artery is expanding under the middle finger, okay? How much the artery is expanding under middle finger, right? So basically, the obliterating finger or the middle finger is giving you what? Is giving you your volume, right? The proximal finger is giving you force. The middle finger is basically giving you volume. Okay. Then let's come to the fifth one after volume. So fifth one is tension. Okay, this is not the tension you get during exams. This is the tension. Basically, the measure of the diastolic pressure. Just if you want to know that the force, basically the force is giving a degree of the systolic pressure. It is an indicator of the systolic blood pressure. Okay, it's just right. It's an indicator of systolic blood pressure, and this tension is basically an indicator of diastolic blood pressure. Understood? So basically, the force is an indicator of systolic BP, and tension is an indicator of your diastolic, right? Then we have the apex pulse deficit, right? The sixth one we wrote, maybe. No, sixth one is the condition of arterial wall. Condition of arterial wall, you just know that I am talking. Just a minute. Okay. So just condition of arterial wall, just understand that I am just talking about what are the things in older people. Okay, basically I'm talking about the people who have gotten old. They have an arterial wall which is uh, of atherosclerosis is basically present. Okay, so I'm talking about atherosclerosis. Basically, I'm talking about atherosclerosis, right? Okay, let's move on to the apex pulse deficit. So sixth one we discussed, and seventh one is the apex pulse deficit. So what is the case here? Apex pulse deficit means you have to feel the pulse on your radial artery as well as the apex beat on the mitral area, right? You know the mitral area, and you have to feel the apex beat on the mitral area as well as the pulse on the radial artery simultaneously. So basically, this is the simultaneous feeling of radial artery, radial pulse, as well as auscultation, not the palpation. It's the auscultation of uh, apex beat, apex beat on mitral area. You know the position of apex beat. We'll discuss in a separate video if you don't, if time permits. Okay. So basically, if you want to give the review, right? If you are in a first year, let's say you are in the first year, and you are basically presenting the radial pulse. Some examiner asks, first you have to take the permission from that person, consent and all. Consent is not much important in case of radial pulse, but it creates a good impression on an examiner, right? So you will say that in sitting position after 5 minutes of you can say resting state, in resting state, or after 5 to 10 minutes of rest, the patient pulse is dash per minute 60 to 100. Just makes you to put the range between 60 to 100. since you are in first year. Okay, and if you're in a clinical years, then you have to tell the exact which you measured. Okay, 60 to 100 or any number you put. Okay, in the right radial artery. Okay, the rhythm is regular, normal force, normal volume and tension. Arterial wall is not palpable. It is palpable in case of older people, right? So here it is not palpable. No apex pulse deficit, no radio-radial, no radio-femoral delay is present. Okay, this is the and other peripheral pulses are said to be normal, right? So this is the normal report, normal pulse report, right? What are the peripheral pulses? Now, if you want to know, peripheral pulses. So many peripheral pulses are there, like your femoral pulse, popliteal pulse, posterior tibial pulse, dorsalis pedis pulse, then brachial pulse. Okay, carotid pulse. Many things are there. Carotid pulse, brachial pulse. Then I told your what temporal pulse, posterior tibial, dorsalis pedis. Many things are there, right? These are the things. Femoral pulse, right? Important one. Femoral pulse means popliteal pulse will be there also, right? These are the things which you have to know. Then I'm giving an overview of the pathological pulses quickly. We'll wind up the video. Then just an overview of pathological pulses. What are the pathological pulses? So basically, if I talk about pathological pulses, okay, uh, we can have a low volume pulse which is called as the pulsus porus. Okay, sorry, pulsus parvus. Okay, or you can have a high volume pulse. High means magnum. Okay, big. So pulsus magnum. Okay, so first you can have a low volume pulse which is called pulsus parvus. Parvus means small. Okay, or you can have a high volume pulse which is called the pulsus magnum. Right? Magnus. Sorry, Magnus. Okay, so low volume pulse, where you will get this low volume pulse or the pulsus parvus is basically seen in case of arterial stenosis. Okay, in case of pulmonary stenosis, these conditions in atrial stenosis, in pulmonary stenosis, in these conditions. High volume pulse, where you'll see in the aortic incompetence. Okay, in case of aortic incompetence, in case of anemia, fever, old age, these conditions, anemia, fever, old age, this type of conditions. Okay, so we knew here two terms importantly: pulsus parvus and pulsus magnus. Okay, these two things. Understood? Now we'll see how a wave of a normal pulse looks. Okay, then we can understand the three type. I will cover just basic three types of abnormal pulses. Like one is called as the anacrotic pulse. Okay, one is called as the dicrotic pulse, and other one is called the Corrigan pulse. Okay, Corrigan's pulse or Waterhammer pulse. Okay, so basically we are covering the normal pulse wave, how the normal pulse looks like, and what are the parts you have to understand. So normal pulse is basically this type of shape. Just I'm drawing, just see. This one is a normal pulse wave. Okay, this is a normal pulse wave. It has three types of waves, two waves and a notch. Okay, so just basically just understand this one. Here is a separation, and this part is called the systolic part, and this is the diastolic part. Okay, This wave which is going upwards like this is called the P wave, percussion wave or the tidal wave. Okay. So P wave, or you can say it as the T wave, the percussion wave or the tidal wave. Then we have it notch here. You can see a notch here. You can see a notch here, N for notch. This is called as a dichrotic notch. This is called as a dichrotic notch. Okay. And we have a wave which is coming down. This is called the dichrotic wave. Okay. After this dichrotic notch, there appears dichrotic wave. So this one, this whole part, basically this part is called as the D wave. You can just write dichrotic wave. Understood? Okay. What are the meanings basically? P wave or T wave, percussion wave. This is the ejection. The cardiac cycle. So there is a diastole and a systole. So this is systolic part. P wave is in systolic part. So basically, when the ventricles are ejecting out the ventricles are ejecting out the blood when the heart contracts, is basically causing this P wave. Okay, understood? So ejection of blood from ventricles in systole causes P wave. Okay, understood. Then, what is the cause of dichrotic notch? Okay, so basically, when the blood is ejected from the ventricle, then afterwards, due to rebounding of blood against the closed aortic valve, basically when the aortic valves are closed in diastole, when diastole starts, the aortic valve must be closed, right? So dichrotic notch is basically a representation, or it is due to the closure of the aortic valve first. Okay, this is the closure of aortic valve. This is due to the closure of aortic valve. Okay, yeah, dichrotic notch. And dichrotic wave is basically rebounding of blood against the closed aortic valve and diastole. So basically, the blood will try to rebound, but it can't. Okay, I know it can't, but it tries to rebound, right? So basically, this dichrotic wave is appearing. The increased wave, or you can say positive, more positive wave, is basically appearing due to rebounding of blood against a closed aortic valve, against a closed aortic valve. Okay, this is the dichrotic wave. So basically, this picture is very important. You can just take a screenshot if you want, and we can move ahead. That okay. So let's discuss a pulse which is called the anacrotic pulse. What is an anacrotic pulse? Okay, anacrotic pulse. So how an anacrotic pulse basically looks? We have something called as an anacrotic notch. Okay, anacrotic notch. Dicrotic notch is separate. We can have an anacrotic notch here. So anacrotic notch is not normally visible in this pulse, but just to understand, just to remember that the anacrotic notch is seen predominantly, is seen very prominently in case of this anacrotic pulse. Okay. So you can have this type of shape. You can have like this, okay. And this is a A wave. A wave means anacrotic wave. Anacrotic wave seen predominantly. Okay. This is a normal PT wave, and the D wave. This is the dichrotic notch N. Okay. And what is the condition? Just to remember one condition since you're in first year. A for aortic stenosis. So basically, when the aorta stenosed, okay, when the aorta stenosed, there is an increased pressure in this aorta, okay, and basically, thereby the blood flow in the systole is basically an showing a reflection of increased pressure, right here in this part. Okay, that's why there is a bulge appearing. So anacrotic wave, which is not normally seen in the normal pulse, is appearing in the anacrotic pulse, which is a pathological pulse, right? This is the anacrotic pulse. Then we can have something like your dicrotic pulse. See, dicrotic notch and dicrotic this you can say dicrotic wave is normal. Okay, it is appearing in normal pulse. Okay, but in dicrotic pulse, what is happening, that we have an abnormally large dicrotic wave. We have an abnormally large dicrotic wave. So basically it appears like this, somewhat like this. Okay, the dicrotic wave, this is a P wave, but this is the D wave. And normally what happens, this is a normal pulse, right? So dicrotic wave is basically shorter than the P wave or percussion wave. Here it is, just you can see it is appearing like a twice beating curve, right? So basically this is also known as twice beating pulse, also known as twice beating pulse. Okay, and one condition you have to remember, dicrotic, like just you remember like this, that T, so T for typhoid fever, T for typhoid fever. So in typhoid fever, you will get a dicrotic pulse. Okay, and it is also seen in a febrile states. Okay, like typhoid fever is one of the febrile states. You can have many types of febrile states. Okay, we'll discuss in fever chapter someday. Understood? So it is twice beating pulse or the typhoid fever, right? Okay, anacrotic is done, dicrotic is done. Then we'll move to another one, which is called as your water hammer pulse or the Corrigan's pulse. Water hammer pulse or the Corrigan's pulse. Okay, this name is important. So here, what is basically occurring? We have a rapid upstroke and a rapid downstroke. Okay, here we have a rapid upstroke and a rapid downstroke. Okay, this upstroke, this one is very rapid. This is a rapid upstroke and a rapid downstroke, which is occurring like this and like this. Okay, like if you're beating a hammer on the water, the waves are coming like that. Okay, the ripples are created. Like this, an analogy is created, which is called the water hammer pulse or the Corrigan's pulse, right? Corrigan's pulse. It is seen in the case of seen in aortic regurgitation. Is seen in aortic regurgitation. Okay. Okay, just see here. This is a normal pulse. This is the P wave, the D, and this is the dicrotic notch N. This is a slow rising pulse as seen in aortic stenosis. This is a slow rising pulse as seen in aortic stenosis because this part is stenosed, right? So it is a slow rising pulse. You can see this type of pulse. Just a minute. Yeah. Then we can have a Bisfrien's pulse. A Bisfrien's pulse. Okay. This occurs whenever the aortic stenosis is mixed with aortic regurgitation. So aortic stenosis and regurgitation you must have been knowing. Okay, this is the aorta, let's say. So stenosis of aorta means the aorta is narrower here. Okay, and aortic regurgitation means the blood which is going into the aorta is basically regurgitated. Okay, this is the blood is basically there is a regurgitation. Okay, so aortic stenosis and aortic regurgitation, when it mixes, okay, it gives a Bispherians pulse. Okay, two waves are there and there's a prominent slow waves. Okay, non just don't get confused between normal and Bispherian pulse. You can see the dichrotic wave is basically very small. Okay, the notch is very small. Here the notch will increase in its whole width. Okay, then we have a collapsing pulse. This in an aortic regurgitation. Okay, collapsing pulse in some contexts is referred to as this water hammer pulse or Corrigan's pulse basically. So there is a rapid upstroke and a rapid downstroke which is occurring here. In there's a slight difference in your water hammer or this Corrigan's pulse is basically this type of pattern is basically formed in case of your Corrigan's pulse. Okay, this is also seen in the case of aortic regurgitation, right? Understood? These all pulses done. So this is about your aortic pulse. I covered a practical aspect of medicine, and in future also will continue covering other things as well. That was a superficial discussion on pulse. If you want to read it deeply, then do follow the clinical textbooks. Like in Harrison, it is given very well, and in your other than DSAU and other medicine practical books are there. Okay, the manuals are there. You can follow them all. Okay, for this pulse topic. That's all. And if you want a specific topic to be covered, you just comment on below the video. And I know many topics are pending for me as well. I'll try to cover as soon as I get some time from my schedule. So that's all. If you have any doubt, do ping me on Biswanath.Tripathy underscore. This is my Instagram ID, as I always say. You can just DM me for your doubts, as well as if you want to know any other things as well. Okay, related to your academics. That's all. Let's meet again in some another video. To then, take care and bye bye.